Now we're going to talk about glaucoma, which is also from chapter 21. Characterized by a group of disorders, you'll have increased IOP and consequences of elevated pressure, optic nerve atrophy, and peripheral visual field loss. From glaucoma is largely preventable with early detection and appropriate treatment. Genetic factors have been identified in some types of glaucoma. Open angle glaucoma, the outflow of the aqueous humor is decreased in the trabecular meshwork. In essence, the drainage channels become blocked like a kitchen sink. Damage to the optic nerve can then result. Primary angle closure glaucoma is caused by a reduction in the outflow of the aqueous humor that results from angle closure. Usually, this is caused from the lens bulging forward as a result of the aging process. Angle closure may also occur as a result of pupil dilation in a patient with anatomically narrow angles. An acute attack may be precipitated by situations in which the pupil remains in a partially dilated state long enough to cause an acute and significant rise in IOP. This may occur because of drug-induced mydriasis or emotional excitement or darkness. Drug-induced mydriasis may occur not only from topical preparations but also from many systemic medications, both prescription drugs and over-the-counter. Check drug records and documentation before administering medications to the patient with angle closure glaucoma, and instruct the patient not to take any mydriatic producing medications. The patient with untreated glaucoma has tunnel vision, quote unquote tunnel vision, in which only a small center field can be seen and all peripheral vision is absent. PACG causes sudden and definite symptoms. Manifestations of subacute or chronic angle closure glaucoma appear more gradually. The patient who has had a previous unrecognized episode of subacute angle closure glaucoma may report a history of blurred vision, seeing colored halos around lights, ocular redness, or eye or brow pain. IOP is usually elevated in glaucoma. Normal IOP is 10 to 21. In a patient with elevated pressures, the doctor usually will repeat the measurements over a period of time to verify the elevation. In open angle glaucoma, IOP is usually between 22 to 32. In acute angle closure glaucoma, IOP may be greater than 50. Diagnostic studies can be completed with slit lamp microscopy, peripheral and central vision tests, and ophthalmoscopy. In open angle glaucoma, slit lamp microscopy reveals a normal angle. In angle closure glaucoma, the examiner may note a markedly narrow or flat anterior chamber angle and an edematous cornea, a fixed and moderately dilated pupil, and ciliary injection. Measures of peripheral and central vision provide additional diagnostic information, whereas central acuity may remain 20/20 even in the presence of severe peripheral visual field loss. Visual field perimetry may reveal subtle changes in the peripheral vision early in the disease process, long before actual scoptomas develop. In acute angle closure glaucoma, central visual acuity may be reduced if the patient has corneal edema, and the visual fields may be markedly decreased. As glaucoma progresses, optic disc cupping may be one of the first signs of chronic open-angle glaucoma. The optic disc becomes wider, deeper, and paler, light gray or white, which is visible with direct or indirect study. From developing optic nerve damage. Therapy varies with the different types of glaucoma. Initial treatment in chronic open-angle glaucoma is with drugs. You can look at Table 21-7. The patient must understand that continued treatment and supervision are necessary because the drugs control but do not cure the glaucoma. With ALT, or argon laser trabeculoplasty, that's a non-invasive option to lower IOP when medications are not successful, or when the patient either cannot or will not use the drug therapy as recommended. ALT is an outpatient procedure that requires only topical anesthetic. The laser stimulates scarring and contraction of the trabecular meshwork, which opens the outflow channels. ALT reduces IOP most of the time. The patient uses topical corticosteroids for approximately 3 to 5 days after the procedure. The most common complication is acute postoperative IOP rise. Follow-up exams are scheduled with the doctor 1 week after the procedure and again 4 to 6 weeks following surgery. Focus. Angle acute closure glaucoma is an ocular emergency that requires immediate intervention. Miotics. You can go ahead and look at Table 21-7 and oral or IV hyperosmotic agents, including glycerin, liquid, isosorbide solution, and mannitol solution, are usually successful in immediately lowering the IOP. A laser peripheral iridotomy or surgical iridectomy is necessary for long-term treatment to prevention of subsequent episodes. These procedures allow the aqueous humor to flow through a newly created opening in the iris and onto normal outflow channels. One of these procedures may also be performed on the other eye as a precaution, because many patients often experience an acute attack in the other eye. Glaucoma is a chronic condition and thus has long-term management concerns and ramifications. Families may need to become primary care providers if the patient is unwilling or unable to accomplish eye drop administration or other self-care activities. Risk for injury related to visual acuity deficits, self-care deficits related to visual acuity deficits, acute pain related to pathophysiologic process and surgical correction, and non-compliance related to inconvenience and side effects of glaucoma medications. Visual impairment, understanding of disease process and rationale for therapy, compliance with all aspects of therapy, and no post-operative. Loss of vision because of glaucoma is a preventable problem. Teach the patient and family about the risk for glaucoma and that it increases with age. Emphasize the importance of early detection and treatment in preventing visual impairment. A comprehensive examination is important in identifying persons with glaucoma and those at risk for developing glaucoma. The current recommendation for an eye exam is every 2 to 4 years for persons between the ages 40 and 64 years old, and every 1 to 2 years for patients 65 years and older. African Americans in every age category should have examinations more often because of the increased incidence and more aggressive course of glaucoma in these individuals. Nursing interventions are directed primarily towards the patient with acute angle closure glaucoma and the surgical patient. The patient with acute angle closure glaucoma requires immediate medication to lower the IOP. It must be administered in a timely and appropriate manner according to the doctor's prescription. Most surgical procedures for glaucoma are outpatient procedures. The patient needs post-operative instructions and may require nursing measures to relieve discomfort related to the procedure. Patient and caregiver teaching after eye surgery is discussed in Table 21-3. Because of chronic nature of glaucoma, remind the patient to follow therapeutic regimen and follow-up recommendations as prescribed by the doctor. Provide accurate information about the disease process and treatment options, including the rationale underlying each option. In addition, the patient needs information about the purpose, frequency, and technique for administration of anti-glaucoma drugs. Encourage compliance by helping the patient identify the most convenient and appropriate times for medication administration, or by advocating a change in the therapy if the patient reports unacceptable side effects. And I think we already went over the many older patients with glaucoma have systemic illnesses or take systemic medications that may affect their therapy. In particular, the patient using beta-adrenergic blocking glaucoma agent may also experience an additive effect if a systemic B-adrenergic blocking drug is also being taken. So all glaucoma agents are contradicted. All beta-adrenergic blocking glaucoma agents are contradicted in the patient with bradycardia, heart block greater than first-degree heart block, cardiogenic shock, and overt cardiac failure. The non-cardioselective B-adrenergic blocker glaucoma agents are also contradicted in the patient with chronic obstructive pulmonary disease or asthma. The hyperosmolar agents may precipitate heart failure or pulmonary edema in the susceptible patient. The older patient on high-dose aspirin therapy for rheumatoid arthritis should not take carbonic inhibitors. The A-adrenergic agonists may cause tachycardia or hypertension, which may have serious consequences in the older patient. Teach the older patient to occlude the puncta to limit the systemic absorption of glaucoma medications.